Welcome back. Today we will see how we can read a chest X-ray. You will first confirm the patient and image details before reading a chest X-ray, which is very important, and also understand the clinical context in which the chest X-ray was taken. Now, then you will assess the image quality. We remember it under the mnemonic of RIPE. That is, we look for rotation, whether it is an inspiratory or an expiratory film, for projection, whether it is a PA view or AP view, as well as look for exposure. So, that is a chest X ray. How will you look for rotation? So, you can central green lines are the spine, and you look for the distance from the spine to the middle end of the clavicle. It should be equidistant on both sides. If the film is rotated to right, that means the distance from the spine to the middle end of clavicle on the right side is shorter compared to that of left. So, in a rotated film, you cannot properly interpret a chest X-ray. Now, coming to whether it is an inspiratory or expiratory film, we prefer an inspiratory film for clear viewing of the lung parenchyma. So, in a proper inspiratory film, you can see up to the posterior border of the 10th rib as well as up to the anterior border of fourth, fifth or sixth rib. So, if you can see the posterior border up to the posterior border of 10th rib, then you say that it's a proper inspiratory film and you can read it properly. Now, to say whether it's a PA view or AP view, we have two or three features like the clavicles are more horizontal in a PA view so that the upper zones are clearly seen. The scapula are more lateral so that the lung zones are clearly seen. And the cardiac shadow is more prominent compared to the vertebral shadow. The posterior ribs are distinct. All these tell that it is a PA view even if you need not look at the markings on the X-ray. Now, why do we prefer a PA view? Because all intrathoracic structures are correctly positioned and proportioned in a PA view. In an AP view, sometimes it may be when the patient is really sick, you cannot go for a PA view because for that the patient has to sit or stand up. So we go for an AP view where we cannot say about cardiomegaly and other etc. Now, in a chest X-ray, the most dense is the bone, then comes the fluid, then comes the fat and skin, and then comes the air in the air, which is the least dense or black in color. So there, the air will be black, the lungs will be black in color, and the hard shadow will be, and the diaphragm will be white in color. That is the basis of that silhouette sign, which will come to later. Now coming to exposure, to say a film is adequately exposed, the thoracic vertebrae should be just visible through the cardiac shadow. The lung marking should be clearly visible up to the peripheral lung fields. The hard borders should be well defined. And it is said that you can see the intervertebral disc spaces of up to T4 to T4, T5 vertebra, not very clearly, but through the cardiac shadow. So that is when you say that the exposure is adequate. So that's an adequately exposed film. Now, in a chest X-ray, you divide the lung into zones, not lobes. So, up to the posterior border of the second rib is the upper zone, second to fourth is the mid zone, and below the posterior border of the fourth rib is the lower zone. So, that is define the structures or whichever shadows you see in the lung in these zones, not lobes. Now, you also have to carefully evaluate all the interfaces between the lung and the adjacent structures. That is, you look for the lines or stripes as well as silhouettes. So, one is the paratracheal stripe, which you can see here. Usually, it is less than 4 millimeter. If it is more than 4 millimeter, it could be due to lymph node or a soft tissue swelling, etc. There, you can look for the para aortic line, paraspinal line, etc. Whenever there is an aortic aneurysm or a paraspinal abscess, etc., it will be more laterally shifted or it will be wider. So you have to look for these lines and stripes. Also, you can look for the silhouette sign, which is very important. The outlines of the heart and the diaphragm are usually clearly visible because the lungs is very dark in color and the heart and diaphragm are really white. So wherever they are abutting each other, they are clearly visible. But when a portion of the lung that is directly against the heart of or diaphragm, such as the right middle lobe, becomes consolidated, it acquires a soft tissue density similar to that of the heart, so that the margins become indistinguishable. So we can say which lobe of the lung is involved. If the silhouette sign is positive, that means the middle lobe is involved. Like in this patient, because the middle lobe is in direct contact with the heart. So here you can see that the right border of the heart is not clearly seen. So that means the right middle lobe is involved. Likewise, here the left border of the heart is not clearly seen. So the lingula is involved. Also, after the looking for the thoracic structures or lung shadows, you can look for the cardiac shadow. You know that the left border of the heart should be looked for straightening, etc. It is formed by the aortic knuckle or aortic knob, then the main pulmonary artery, then left atrial appendage as well as left ventricle. Likewise, right border is formed by the right atrium and the right ventricle, and you can see the pulmonary arteries also arising from on the sides of the right ventricle. Now, whenever you read a chest X-ray, you also have to look for certain hidden areas where sometimes you may miss this. That is the apical zone, the hilar region, the retrocardiac, and the subdiaphragmatic area. So these are the hidden areas. The apical zones, sometimes you can miss a Pangos tumor in the apical zone. The hilar region, sometimes there can be lymph nodes or soft tissue swellings. The retrocardiac region might show some masses, swellings, etc. Subdiaphragmatic, subpulmonic abscess, etc. in the subpulmonic region. So all these areas should also be looked for while reading a chest X-ray. Now, so that what are the 10 points while reading a chest X-ray? First of all, confirm the patient details, assess the image quality, the RIPE method. Then inspect the airway, trachea, and bronchi. Examine the lung. As I told you, the lung is divided into upper, mid, and lower zones. Review the pleura and the costophrenic angles. Assess the hyla and mediastinum. Evaluate the heart size and the borders. There, I should say that when you will say about cardiomegaly, when the maximum transcardiac diameter is more than 50% of the transthoracic diameter, you say it as cardiomegaly. You should inspect the diaphragms, then review the bone and soft tissue. Sometimes you can see subcutaneous emphysema or a lymph node, calcified lymph node, etc. in the soft tissue. You can look for bone in the bony cage, rib notching, or a fracture of the rib, etc. in the bones. You can also check for tubes, lines, and hidden areas before reporting. So that is how you read a chest X-ray. Thank you.